We've got about 45 people on. Some will join here. The talk today is more about language disorders that are classified as primary progressive aphasias, or what we call PPAs. So this is a unique subset of progressive cognitive disorders, and we'll just kind of run through things here. These slides have been rotating through. Your code is 53 MASH. Trying to make sure to include your names. And then I don't have any disclosures here for this talk. Objectives wise, I do want to at least define what this term means, primary progressive aphasia. It's a bit of a mouthful. We'll go through some case examples, just highlighting that these technically fall under both frontotemporal dementia subtypes, usually affecting the left side of the brain where language is, at least in the majority of patients, and realize that there is an Alzheimer's subtype called logopenic aphasia. We'll briefly discuss a few treatment options that at least can help, although not fix the problems, and then discuss the role of involving a speech language pathologist, both to help with diagnosis, which can be quite tricky, but also with just ongoing education of the disorder and any assistance with communication devices. So the definition of this, it involves a spectrum of progressive degenerative disorders that are characterized by initial language problems. This is a clinical syndrome. It doesn't necessarily tie to one specific pathology in the brain. And it doesn't necessarily include patients that have language right? Maybe they started with some memory symptoms and then it evolved into language symptoms. Those are not classified as primary progressive aphasias. I will tell you this can be tricky, and it really kind of depends on what questions you ask or what symptoms they first notice, right? A lot of that comes down to the history, but that's the general definition of these. And I'll tell you that even experienced cognitive neurologists, so trained in cognitive disorders, find this topic challenging. One reason is the incidence is pretty low for these. I bet it's higher than this. We just don't recognize it, but it's still pretty low. And even, if we wanted to further delve into detailed language testing, that's quite time consuming and really requires expertise in interpreting as well. For my primary care and general neurology colleagues, I don't expect you to be able to differentiate between these subtypes. Just recognize that not all language disorders are the same. And then, recognize that if there is a language complaint, further workup would include kind of what we recommend with a detailed neuropsych testing. One, to see, is language the only thing that's impaired? That could be a multi-domain dementia syndrome that just happens to involve language. You'd want to get a brain MRI scan and to see if there's any structural damage to the language centers. And speech pathology is your ally here in trying to help differentiate these, right? Or a speech therapist. So, at University of Kansas, Jamie Johnson, I work with often, and not all speech language therapists and pathologists are, fully recognize the different subtypes of primary progressive aphasia, but they can at least help get a good baseline language evaluation for your patient and talk about any adjustments for communication devices. When I sort of think of things as an overview, when the patient comes in with a certain complaint, I usually try to go down a certain path, right? If it seems to be pretty memory predominant, then I'll try to ask more questions about that. But if somebody comes in suggesting that they're having troubles with getting their words out or language, then asking questions related to those things, right, is important, and focusing on that rather than just kind of asking, are you having difficulties with memory? So that's one key tip, right, is try to figure out, well, what's causing the issue with language? Are you having troubles understanding language? Sometimes it's just as simple as their text messages don't have full sentences in them, right? And that's a change. Or difficulty naming things. They may start calling objects different names. So that's sort of one key point here. So if you've got a patient that comes in, so this is a 52-year-old, so younger side of things for this patient, and most patients come into my clinic with quote unquote memory problems or memory concerns that are pretty undifferentiated. They're getting gradually worse over the last 2 years. You notice in talking with him that he uses like generic terms, this and that, often to describe things. He struggles with naming certain things within the history, and more generic with his language. A bedside screening tool like the Montreal Cognitive Assessment, he scores almost normal, 25 out of 30, but he struggles in the naming and verbal memory components. So like when you have him try to name these three things, a lion, a rhino, a camel is what we're expecting, right? He says a cat, a hippo, and a camel. So he's kind of reverting back to some more generalized term on the cat and mixing up the hippo and rhino there. If you do more detailed language testing, this would again be by someone like myself or a language specialist. He's really struggling to name things to confrontation. So getting like more than 5 incorrect on this test is abnormal, and he's getting only half of them correct. If you ask him to repeat things, he can repeat language just fine. His actual speech motor production is normal. So it seems to be more of a naming problem. We think about kind of what the different parts of the brain do. Generally, this temporal lobe, especially on the left side, is responsible for most of language, although there is this sort of also language network across here, especially producing language here in what we call Broca's area. At least from what we're getting from the history, his main problem seems to be in the language domain. And when we look at, well, okay, are there different clinical criteria that are a little more expansive than what I told you in the initial slide? Same thing here, where the primary feature needs to be language, right? That's kind of what we're seeing here. It needs to, that deficit of language is what's impairing his daily activities, not some other feature of cognition. And again, that needs to be kind of the more prominent deficit. We can subtype this a little bit. There's these 3 subtypes, which we'll give you some case examples of. So non-fluent is like troubles with getting the speech out, right? So we call that halting speech or effortful speech. Sometimes it's really slowed speech. I've even seen patients where it's been called functional speech disorder just because they're really slow with how they're getting the words out. You can also have apraxia speech, where it's like the motor planning is just difficult. There's issues with impaired repetition of sentences that goes along with logopenic aphasia. They can also have difficulties with recognizing objects. But this one over here, which I'll kind of highlight, is really just mostly an impairment of confrontation naming. And really, there are a couple other features here that I'm not going to go into detail of, but it's that impaired object knowledge where it's pretty isolated is where we start to think of this variant. And it really corresponds with neuroanatomy. When we look at like somebody that presents with behavioral frontotemporal dementia, they have like the right front part of the brain as the primary area of changes on like a glucose PET scan, whereas our semantic variant patients tend to have this left side, especially the anterior portion of the temporal lobe, that is struggling, and that's kind of right where the naming center is in the brain. And then there's some other ones labeled down here. And so that individual has more of what we would call a semantic variant of a frontotemporal dementia. And that's important to recognize too, as far as from if a speech pathologist kind of classifies this better for you, because counseling a patient on, well, the right side of the brain is going to eventually be involved. Here's a case where both sides are involved and actually started more on the right side. They can have a lot more behavioral symptoms, right? And so counseling that those things are expected, at least over time. What we're learning about these semantic variants too is they're often not a family history. It's usually not genetic. And they also tend to move a lot slower. So we're talking, more of like sometimes up to 10 to 15 years of progressive symptoms. So again, as we learn more about these and can categorize them better, it'll help with our as far as our prognostication and our counseling. So the second one comes in with a slightly different complaint. Again, 2 years of issues, but they're more of troubles getting my words out. So it's really nice to be able to review maybe an email or text message from a family member so what are the things you're noticing, right? And You notice that if you look at their text messages, they're leaving out a lot of connecting words. And there's a lot of simple fragmented sentences. And so that's a little bit of the detective work that comes into just trying to solve some of these puzzles. They can repeat simple words, so that's not an issue for them. They're able to recognize objects, so different than our last patient as far as what parts of language might be affected. They're having some right-handed apraxia, so that's just difficulties with fine motor skills and maybe difficulties with mimicking certain tasks, like we have them try to pretend you're hammering a nail, right? Things like that. They're not able to do those skills as well, especially with their right hand, which the left side of the brain controls the right side of the body. So that's a clue. When we kind of look at this differentiation again, they most fit with this sort of effortful, speech, getting their words out, but also the sort of agrammatism, these difficulties with having complete sentences and things like that. So they better fall into this group. And if we look at a PET scan, so this patient's PET scan actually was quite revealing. The right side of the brain, so gray is normal here, the right side of the brain looks very normal. There's really nothing abnormal on that side, but the left side is significantly struggling. And right in that area that I circled earlier called Broca's area, which is producing speech, that's where their kind of epicenter is of their disease. And it's really affecting this whole language network here. And this also explains a lot of the asymmetry we see on exam. They've got caudate and putamen hypometabolism, which is really involved in that apraxia network. And then on detailed cognitive testing, they had more frontal executive testing problems, which is what you would expect in this type of scan. One thing to note, so when you see this amount of asymmetry, I guess it's not totally uncommon. We do see a lot of asymmetry, but this amount of asymmetry is highly suspicious for a certain genetic mutation called progranulin. And I just highlight that because we have a study ongoing in progranulin mutations. It's a pretty rare genetic test. It's something we don't test our patients in generally, but there is free testing through the study. And we also have a connection with Invitae through our clinic that does free testing. And it's just being able to identify the mutation is the first step to getting patients enrolled. And we're actually trying to target that gene in this study. So it's one that's kind of an exciting study. It's just hard to recruit for when we are struggling to find the mutation. This last one, so I don't know why this ended up here, but this is an 82-year-old. So again, 2 years history of just kind of general cognitive concerns. On further questioning, she's also having difficulty getting her words out. A unique thing with her is she's switching her yeses and nos and having a lot of reversals. So like cold is hot, hot is cold. And sometimes she'll even say yes while she's nodding no. So there's a lot of kind of confusion of those yes, no reversals. She's not really having any spelling, reading, or other memory complaints. On testing, she does pretty well with my bedside screening test. This is technically in a mild cognitive impairment range, but no specific pattern of like memory impairment or things like that. Her language exam is pretty much normal, except you notice that she's got a really slowed and distorted speech. So one way that I test this, just a 5-second test, is have them repeat cat 3 times, which is 1 syllable, right? So she did fine with cat, cat, cat. But then when you start adding syllables in there, so catapult, 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 or catastrophe, 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 that's where she really starts to become very inconsistent. She catapult, and there's breaking segmentation of those syllables, and that's where the problem became more apparent. She did have some mild slowing of eye movements, but it's very subtle and otherwise a normal neuro exam. So one note, her MRI was pretty unremarkable, so we proceeded with a PET scan to try to help understand this a little bit better. And hers is pretty focal, but it's right over the premotor areas of the brain. So like whenever you reach to grab an object, the motor cortex back here needs to fire to help you reach for that object. There's a whole premotor area that helps plan that out for you. And that's why our movements tend to be more smooth. And especially as we, get better with movement through childhood, right? A lot of that is just the premotor planning. And so in order to speak, you also have to pre-plan that motor aspect. And so when we see supplementary or premotor areas involved, then that really disrupts the planning, producing, and monitoring of speech. So patients then start to have this sort of slow overall rate of speech, sound distortions. The sort of planning of yes and no can be reversed, and we get a lot of difficulties initiating speech, which is that planning aspect. This is technically called primary progressive apraxia of speech. It's a slightly controversial topic in our field, but most of us that have seen patients like this really refer to it as more of a distinct variant of this non-fluent aphasia. And this is important as we learn more about it, because when we study these cases at autopsy, they're usually due to a certain protein, which is a tau protein here. And a lot of these patients will evolve over time to have sort of atypical Parkinson's syndrome. So PSP is progressive supranuclear palsy. So she had very subtle, slow eye movements, and she has a high chance of developing into PSP in the future. So it's just important to counsel on, we need to know if you're having balance issues or falls, getting her involved with physical therapy early, right? And also with speech therapy, obviously, are important to try to help maintain cognition in the setting of a degenerative disorder. And corticobasal syndrome is another atypical Parkinsonism that can show up kind of with areas within the premotor being affected first. And just a word on logopenic aphasia. So this is, those other ones I mentioned are more kind of in that frontotemporal dementia category. This one's more likely due to Alzheimer's disease. And kind of highlighted here is oftentimes they're unable to repeat long sentences. So if you say something like, repeat this after me, the cat always hid under the couch when the dog entered the room, they start to lose those pieces, especially in the middle, the details. Their internal tape recorder is gone, right? And part of this is because the memory can be affected, but it's kind of that planning out the logical order of that sentence is difficult. Sometimes they can have a slow rate of speech, more because they're always searching for words. So you find them kind of pausing, searching for words. So they'll lose their train of thought mid-sentence. And because this is almost always due to an Alzheimer's disease pathology, they'll often start to evolve more into memory symptoms and look more like a classic Alzheimer's patient. But it starts off differently because it looks more like this when it presents, where it's just really this language network that's getting knocked out primarily early on. And so that's kind of what a PET scan looks like in this disorder. And when we do biomarkers and things, they're positive for Alzheimer's disease. And I'd say it's 90 to 95% of cases. So treatment-wise, a lot of our patients, especially if they're having troubles getting their words out, I mean, we obviously communicate with language. It involves a lot of anxiety. And what tends to happen if they're trying to find that word, well, the stress and anxiety levels go up in the brain. That doesn't help you think of the word. That doesn't help you get out the sentence that you want to say. And so that anxiety can then become a vicious cycle, right? So starting SSRIs can help with that further blocking of speech production, that sort of vicious cycle. So that's important to think about. If somebody has more of a logopenic pattern, again, why the speech pathologist is important to help you maybe differentiate that. Maybe the PET scan is what ends up helping you with that sort of pattern. But those individuals should be tried on donepezil because it can help with some of the memory symptoms that they have and some of the word finding difficulties too. Speech therapy should be initiated in these patients, right? So that involves the apraxia of speech cases, even more beneficial for those, but also for our primary progressive aphasia. There are very low referral rates, and that's an ongoing concern. One is because maybe it's not being recognized, but if you had a patient with balance problems, you would refer them to physical therapy to help maintain balance, right? And the same should go with patients with speech problems. And part of this too is just maybe of how a lack of knowledge of how speech pathology might help. But there was a study that was done where So patients with primary progressive aphasias, 78% experience barriers in accessing speech and language therapy, right? And so part of that is the availability of speech therapists, like maybe in more rural communities. With telehealth and everything now, that's should improve a little bit, at least within the certain state that someone resides in. But these things, so one, it helps with the sort of education, right, aspect of things. As a primary care provider, you're not going to be able to tell them the in-depth literature on primary progressive aphasia, but a good speech pathologist at least can get that started. It's also going to be important to help them communicate, right? So if somebody knows what they want to say, but they can't get the words out, they can start to use soundboard devices or other aspects to help communicate language, right? And there are some interventions as far as practicing language and things that it can at least help some of that functional language. So I'll go ahead and wrap up there. This is basically an overview of language disorders. It kind of highlights that there are frontotemporal dementia variants, which we'll talk about temporal dementia again in the behavioral talk that I give coming up. But this is more of the language variant of frontotemporal dementia. And then recognize that there is an Alzheimer's variant. So these patients can qualify for Alzheimer's disease studies, research studies that we have, even though it's more of an atypical variant. That usually requires biomarkers or some sort of PET scan to help support that diagnosis. And then we do have this FTD progranulin study going on. So anybody that has FTD can at least get the gene tested for. There was a hang up there for about a year because the company was requiring a family history to get the genetic testing done, but that has now been lifted. So it should open up some more avenues there. So I will go ahead and stop there and see if there are any questions. I'll let Kelsey, you can rotate the slides. And I think I saw, okay, everything so far with Mary Beth has been about the code. Okay. Anybody, you can unmute yourself too and ask a question if you'd like. Okay, good question here. So is there any recommendation that you would recommend for intermittent symptoms while inpatient? How strongly do you think that low-dose Keppra would improve AD symptoms? That's an interesting question. So I'll take the first one first. I mean, I think intermittent symptoms while inpatient, a lot of the times why patients are inpatient is often, well, at least from a neurology perspective, is like a stroke, right? And we always get speech therapy involved then. It's hard with intermittent symptoms, especially if patients are having ongoing medical issues. They can have fluctuating delirium and things that can impact language. And it would be really hard to make an aphasia diagnosis, right, when somebody is acutely ill. But if there's enough suspicion, a lot of that comes down to asking the family, hey, have you guys been noticing language symptoms, rather than just kind of what's been happening acutely? And if they have, then maybe getting speech therapists to at least evaluate once the patient recovers and is in the outpatient setting. The second question is asking how much I would think low-dose Keppra would improve AD symptoms. So that's a really interesting question, because I'm working on a talk right now regarding epilepsy and dementia. And there's some ongoing theories that hyperactivity in the hippocampus structures could be a preclinical phase of Alzheimer's disease. And there are actually ongoing research studies trying low doses of Keppra to see if it can help improve symptoms or at least slow down the progression of Alzheimer's. But those are all phase 2 trials. They're pretty preliminary. So I can't say anything definitively on that at this point. Yeah, so you were referring to the phase 2 clinical trial. Yeah, it's a very interesting concept. There's actually a vicious cycle hypothesis that, so when you get amyloid beta oligomers, kind of the smaller versions of amyloid beta, they can be toxic to the cells and disrupt that sort of cell's communication abilities. And it can basically create a hyperexcitability state. And when you do like a standard EEG, you're not going to pick that up. These are deep in the hippocampus structures. It would require depth electrodes to really detect a lot of these low threshold hyperactivity changes, but fMRI and other studies have picked these up. And that hyperactivity, every time a neuron fires, it fires with amyloid precursor protein, which creates more amyloid beta, and that can create a vicious cycle. And so I'm interested in these studies. The preliminary phase 1 trials and the pilot studies looked promising. Some of those go back to 2012. I kind of hoped I would have seen something more definitive at this point, but one of the issues that I see, I don't know specifically about the UCLA one, but some of them are testing it in an Alzheimer's, like a mild dementia stage, and I think that's too late. I really think even the preclinical before MCI would be the right time, but at least MCI, I know there are some trials going on there. The VA is also having a phase 2 trial going on. Yeah, so Melissa asked an excellent question. How do you assess and manage patients whose first language is not English? So there are some standardized batteries for Spanish, and those could be used. I mean, I think even when we refer patients to get neuropsychologic testing, right? They have to sort of qualify that English is not their first language and really try to tailor the exam to a Spanish version, or otherwise that the difficulty then arises if you're using an interpreter that gets a lot more difficult. I think one issue, if you're trying to assess them, right, that history is really the most important part. And does family notice a change, right, in their first language, right? That would be important to note. And then anything that can be done, at least in language specific versions through a speech therapist and things, would be recommended, but they might have to think outside the box a bit. We don't have all the same standardized scores for those in many cases. But that's one of those things too, right? There are other objective tests, right? So if you're picking up on the family's really concerned about their language, it's difficult for me to objectively assess that, right? That's a reason to get like a glucose PET scan. That is agnostic to language, right? So an FDG PET scan would be something that could objectively tell you, is this a frontotemporal primary progressive aphasia or an Alzheimer's variant? And that would be a good role for that type of objective test if you're struggling to do full assessment. So excellent questions. Oh, I missed one here. I should expand my box here. So Maurice asked, is speech therapy recommended for frontotemporal dementia? So not all frontotemporal dementias, more of the language variants. Now, I say that with a small caveat of if the right side is the one that's predominantly affected, that affects behavior, but the left side starts to get affected at some point in the disease process. It's just, for most patients that start out right-sided, by the time the language becomes significant enough, we've reached a stage to where that type of therapy is less likely to be helpful. Whereas when it starts on the left side, it's usually pretty early on, and speech therapy is more useful in that setting. All right. So I do have to get to another meeting here at 12:45. Becky did ask, available for printing. Yeah, I'm going to send them to, I will send them over to Kelsey and Mary Beth. Mary Beth will post them on the EADS website. So that's listed up above. And yeah, so they'll be available for printing there. All right, any burning questions for the last minute here? These are some good questions. All right, well, thank you all. We got up to 70 participants again. I hope this is helpful, and we will be back. Kelsey, do you know the next, is it in 2 weeks again? I gotta look at my schedule here. Should be the 22nd. So, all right, but you'll get an email about it. So, all right, thank you all. I'm gonna head out.